Sir, thank you. Green button to go forward, red back.
All right.
Best of luck.
Good morning. Thanks, David, for the kind introduction, and it's a real privilege to be here as a former Navy surgeon myself to deliver Dr. Watchel's keynote address is humbling and exciting at the same time. And it's great to see a packed house here early morning, and I'm really excited to join y'all and learn together. Could I have my first slide up? Okay, there it goes, thanks. And also want to thank the program committee and the board for inviting me to join you for this fantastic conference. So today I'm going to talk about geriatric trauma, and there's actually, quite a few experts in the room that have done a lot of their academic work, Dr. Manger, Dr. Kokenauer, Dr. Bilal Joseph, on geriatric trauma, and I kind of want to take you through a whirlwind tour of geriatric trauma and some of the work we've done at our center regarding these patients. Nothing to disclose. So today we're going to talk about the objectives. We're going to talk about the physiology of aging as well as frailty, the comorbidities and medications that come along with taking care of geriatric trauma patients, the mechanisms and injury patterns, the geriatric trauma evaluation, like how do you take care of this patient when they arrive to your emergency department, and I'm going to touch a little bit on injury prevention as well. So this is always cute, right? Your little kid running along, falls down, trips, scrapes up their hands and their knees, they wipe everything off, everything's great, it's fun, it's kind of a little bit of laughter. This is not so great, right? And this we're seeing all the time is geriatric patients falling. In fact, kind of interesting story, I had my first fall, I'm not geriatric yet, I'm only 48, but I had my first fall 2 years ago in Chicago. I slipped in the ice in the parking lot, and it's a really scary thing to happen to you, right? So I'm laying on the ground and my kids come running over. I thought they were gonna help me up, they just laughed at me and went in the restaurant. So I felt very alone at that moment, but you realize how scary that might be for somebody a little bit older with some medical problems. So you see our geriatric population is obviously growing across the country. Those of you who are going to still be in practice 10, 20, 30, 40 years from now are going to see this growing every single day. And then that combination with what feels like at my trauma center, I suspect at your trauma center, is like an epidemic of geriatric falls. I feel like it's an all-day, everyday occurrence, and so we better be really good at taking care of these patients. Just like pediatric surgeons and pediatricians say that kids are not just little adults, I think geriatric patients are not just older adults. They're really different than your standard adult patient. And the physiology of aging will affect multiple systems, including cardiovascular, pulmonary, renal, and gastrointestinal. So the cardiovascular system is mostly affected of the intima and the media of the blood vessel, right? The three layers, intima, media, and adventitia. The intima and media are affected by aging. You get increased arterial wall thickness, increased subendothelial collagen, total peripheral vascular resistance, and a state of vasoconstriction. And this is manifested through hypertension. But realize these patients walk around in a vasoconstricted state. In addition, they're vasoconstricted and they can't relax. Right, they don't have the elastin in their blood vessels, they don't have the extensibility, and they don't have the ability to vasodilate anymore. So they're in a vasoconstricted state and can't vasodilate, which really affects their cardiovascular response to injury. If you look at the cardiac physiology, their heart doesn't work as well. Right, there's a lot of words on the slide, but basically the right heart doesn't work as well, the left heart doesn't work as well. The left heart will often have hypertrophy, and the really important thing is they're atrial dependent, right? They need that atrial kick for their heart to work, and they lose that when they get atrial fibrillation, which is a very common complication in these elderly patients. And so that heart's not going to work well, not going to help you get through a patient in hemorrhagic shock or any other shock. The stress response, they don't respond to the adrenergic sympathetic output the body has, so they don't respond to that as well. And they can't rely on their heart rate. They can't raise the heart rate like a kid can to get themselves out of shock. They rely on stroke volume. And that's a real tight balance, right? You want to give them stroke volume to allow them to perfuse, but you give them too much, you put them into failure. But that stroke volume is going to be an essential part of their physiologic response. When you look at the airway and breathing, pulmonary systems, when you talk about the airway, you're going to have airway management issues potentially in these geriatric trauma patients. You may have decreased interincisor distance and decreased thyromental distance. Those are both markers of a difficult airway, as well as loss of lordosis of the spine, right? Their spine is going to be straightened out with that aging. So you may encounter a more difficult airway and more likely to have a higher class Mallampati score than their younger counterparts. The progress of their spine, they're going to get kyphosis and decreased disc spaces. Along with that, they're going to have weakening of their respiratory muscles, so their chest wall doesn't work as well mechanically as their younger population. And then at the microscopic level, at the alveoli, you're going to have decreased elasticity, increased compliance, some emphysematous changes, and mucociliary dysfunction, so they can't clear the secretions out of their lungs as they normally would. When you look at the pulmonary function tests, they have decreased residual volume and decreased functional residual capacity. That to me doesn't really mean that much, but on the opposite of that, what they really have is decreased vital capacity. So they can't take as deep a breath as they could 10, 20, 30 years ago, which has a big impact on us when we take care of them in a pulmonary toilet standpoint, using their spirometry and things like that. So that decreased vital capacity comes with age as well. At the gas exchange level, they have a VQ mismatch, right? They're perfusing and not ventilating certain areas, and they have an elevated PA pressure, right? So not only have systemic hypertension, they're going to have pulmonary hypertension as well, and a decrease in PaO2. So what does all this mean together? That's a lot of science and kind of textbook stuff, but what does all this really mean for the geriatric trauma patient? Well, it means they're going to have a decreased response to hypoxia and a decreased response to hypercapnia. So if you or I get hypoxic, we respond to it, right? We start breathing faster, we start trying to improve oxygenation. If our CO2 climbs, same thing, we start breathing faster, try to improve our ventilation. Elderly patients don't do that, and so they have a higher risk of acute respiratory failure, and it will catch you by surprise. They will look great, great, great until they don't, and then they're in respiratory failure, right? So they can hide a pretty significant problem with hypoxia or hypercapnia until it's too late, potentially. Renal, they probably have chronic disease, and so when someone has chronic renal disease, what do you avoid? Hypovolemia, nephrotoxic agents, IV contrast, and hyperglycemia. So what happens when someone rolls into the emergency department or a trauma center? They're hypovolemic, they get nephrotoxic drugs, they get IV contrast, and they get high sugars in the ICU. So realize that chronic kidney disease, whether you have a BUN and creatinine yet or not, it's there. And take these variables into account when you're managing that patient. Gastrointestinal. Dysphagia is a real challenge to me in these geriatric patients, right? The question to me is, how many have dysphagia before they get to you? A lot. And some people say as high as 20 to 30% of people over 65 will have some form of dysphagia. And that will catch you because now you're in the hospital, you've taken care of the patient, and now they have dysphagia. So did they have it before and they were just managing on their own, or did they develop this during their hospital stay? We actually looked at dysphagia post-intubation in trauma patients a few years back, and we found that older age had a 12-fold increase in dysphagia after intubation. So I think we screen fairly liberally for dysphagia in all patients on the ventilator, but particularly in older patients. And that can be a difficult discussion with the family. If they have dysphagia, do you just let them continue to have the dysphagia that they managed before? Do you put a feeding tube in? That's a fairly complex issue, but realize that dysphagia could be there in the background. In addition to that, you have other gastrointestinal problems like gastroesophageal reflux, gastroparesis, both of which may cause you to have patients who have vomiting during their stay. The vicious cycle, especially in the ICU, of diarrhea and constipation. You know, you're on rounds every day, hasn't had a bowel movement day after day after day. 4 days later, they have profuse diarrhea for day after day after day. So it's obviously kind of a balance in both directions. I'm sure the ICU nurses can associate with that. And then you have malnutrition. Your geriatric trauma patient is malnourished. Just take that. You can do whatever tests you want, but just assume they're malnourished walking in the door. And that malnutrition really is one of the main factors in the vulnerability that comes with aging, known as frailty. And frailty, unfortunately, there's not a perfect definition for frailty, and there's not a perfect screen for frailty, but realize that it exists, right? And that malnutrition is one of the initial parts of frailty that sort of leads down this cycle. So weight loss and malnutrition, sarcopenia, which is that muscle loss that geriatric patients will develop. And again, frailty is not necessarily associated with age. Younger patients can be frail as well, like a chronic renal failure on dialysis patient, and older patients may not be frail at all. But realize that in general, the older you get, the more likely you're going to be frail. And it's also separate from comorbidities and medications as well. So they get that muscle wasting, which leads to a decreased basal metabolic response, decreased strength and power, decreased exercise tolerance. So then what happens? So they start walking more slowly, right? I feel that already. Going up and down the stairs, you're moving more slowly than you were 10 years ago, than I was 10 years ago. Decreased activity, which then leads to decreased total energy expenditure, and then you're back to decreased weight loss and then more malnutrition. So this kind of cycle of frailty, you're seeing a lot more written about this in the literature and how it affects. And frailty affects outcomes poorly across the board. Right? They're going to have a worse outcome if they're frail. So it's going to be important, I think, to better define frailty and better screen for it when the patients come in the hospital. And it's not only physical frailty, there's also social, psychosocial components, psychological components to frailty as well. So hand in hand with this physiology of aging come comorbidities and medications. This is a study that's actually impressed this month in American Surgeon, where we looked at the National Trauma Data Bank to compare, excuse me, older patients and younger patients as regards to their comorbidities and trauma. So you look at the comorbidities along the left and then the younger and geriatric patients, and not surprisingly, the geriatric patients are more likely to have hypertension 30% of the time. I suspect this is probably underestimated. This is registry data coming in from a bunch of centers, and you can realize there may be some underreporting of hypertension or other comorbidities within a registry. They eventually have a 10-fold increase in cardiac disease as well as stroke, 4% versus 0.6%. On top of that, more likely to have diabetes, and again, the chronic renal failure we talked about. For sure, this is underreported at 1%, but realize that it's there in the background. So along with those comorbidities come medications. Some of the most common medications we're going to have for hypertension are going to be diuretics and beta blockers. This, again, is going to challenge us to take care of this trauma patient. They already have a hypovolemic state walking around, right? Now they take their Lasix in the morning and they urinate another liter before they get in their car crash. So you get a patient who's hypovolemic at baseline, more hypovolemic, and then you put them in a crash and they have hemorrhagic shock, you're already further behind the 8 ball after that injury. In addition, we know their cardiovascular system doesn't respond normally. Now you add beta blockers, so their heart rate looks like it's 60. Well, everything seems fine, right? Don't be fooled by a normal or slow heart rate in an older person. They can be in hemorrhagic shock with a normal heart rate and a normal blood pressure. Don't let that cardiovascular physiology throw you off. And then finally, antiplatelet agents. Probably the most common drug we're going to see on these people is going to be an aspirin, even a baby aspirin a day, or other antiplatelet agents. Here's a long list of antiplatelet agents with a lot of information. Let's kind of narrow this down. Aspirin and Plavix are the big ones that we see, and the platelets are ruined for the lifetime of that platelet, right? So they either need new platelets given to them, or they need to make new platelets to offset these medications. The question is, are they inhibited? Is the aspirin working? Is the Plavix working? You really don't know necessarily. One thing that you can use is a thromboelastogram or a TEG, and this is typically used to determine if somebody is thrombotic early in their hospital stay or if they're breaking down clot. The TEG kind of represents the entire strength of the clot. But there's a component of the TEG or a thromboelastogram you can use to look at the platelet inhibition. The arachidonic acid pathway looks at aspirin, and the ADP pathway looks at Plavix. And you can use these to determine if somebody has any inhibition from their antiplatelet agents, right? Because internists just put people on aspirin and put them on Plavix and send them out. They don't know if they're inhibited. We assume they're inhibited, but I think for us it's important to know whether they are inhibited or not. So you look at this patient's TEG, they have a 0% inhibition. The dark line TEG matches up with the gray line TEG, means that clot is full strength. Where you look at this one down here, that gray line is inhibited. It's not near as good a clot, right? The platelets count is normal and the TEG looks normal, but the patient is 90% inhibited. So those platelets aren't working because of the aspirin, because of the Plavix, or interestingly, just because of the trauma. Just a trauma is going to inhibit platelets. So we've actually gotten pretty aggressive at looking at inhibition in platelets in all our ICU admissions and all our intracranial hemorrhages. And the two things you can use potentially to reverse that platelet inhibition are DDAVP or platelets themselves. We published a study, it's in press actually, EPUB had a print that looked at inhibition of platelets, and we found that a inhibition of greater than 60% in patients with intracranial hemorrhage on the ADP or Plavix pathway was associated with an increase in mortality. So we've actually now instituted a program where we use either DDAVP or platelets or both in order to reverse that inhibition and hopefully prevent that hemorrhage from progressing and hopefully improve outcomes. I think more studies to follow on that from our institution. It'd be interesting to see what that shows. But I think if you have patients coming in and you have a thromboelastogram, this geriatric population is a great group to look at their total clotting ability as well as their platelet function. And then anticoagulants. Anticoagulants, kind of the bane of our existence as trauma surgeons, right? Everyone remembers the clotting cascade that we all learned in some school or another. Most commonly a few years back, everyone was on warfarin. And I hated warfarin. Now I actually kind of like it, and I'll tell you why. But warfarin inhibits factors 2, 7, 9, and 10, and it was easy. There was a there was a lab we could draw, look at the INR, okay, it's normal, don't worry about it, or it's high, let's correct it. It was easy. We could give plasma to correct it, or even more recently, prothrombin complex concentrate. Warfarin was anticoagulated, we could fix it. That was actually okay. Things are never so bad they can't be made worse, right? Again, I used to hate warfarin. I love warfarin now. It's easy to take care of. But now what you have are the target-specific oral anticoagulants. These are really a challenge for us, and they are everywhere in our patient populations. I mean everywhere. Everyone's taking these drugs. Right, you have the direct thrombin inhibitor, dabigatran or Pradaxa, and then you have multiple 10A inhibitors, Xarelto, Eliquis, and some other ones that are in development. Right, so now we have specific targets, you know, either thrombin target or 10A target that have really almost replaced warfarin as anticoagulants. And the perspective is, why are these everywhere, right? The cardiologists, this is their bread and butter. They get a patient who needs to be anticoagulated, they're going on these medications. Right, to us, it's the greatest evil known to man. Right? It's a terrible epidemic, along with the falls are these anticoagulants that are a real problem. What about the studies? There are a slew of studies supporting the use of these target-specific oral anticoagulants. And the reality is every single study was sponsored by industry, every single one. But it doesn't matter. They're out there with thousands of patients enrolled. And the drugs work, right? They are either as good or better than warfarin for atrial fibrillation, as good as warfarin for DVT and PE, as good or better than warfarin for major bleeding, and then actually better than warfarin for intracranial hemorrhage. They're talking about spontaneous intracranial hemorrhage. So these drugs are here to stay, without question, right? We are going to keep taking care of these patients. Real problems with these medications, right? Are they anticoagulated? You have no idea, right? Warfarin, you get somebody, their INR is 2.5, they're anticoagulated, right? With these drugs, it's unclear. They're not designed to be tested after the patient starts taking them. They're just given to them and you go about your business. So are the patients anticoagulated? Well, we can use PTT, maybe we can use a TAG, but it's not clear each drug in each different patient, is the patient anticoagulated or not. In addition, until recently, how would you reverse these drugs? There was no reversal agent, right? You let it wear off, you give them charcoal to bind it, you dialyze them, or maybe you give them prothrombin complex concentrate. But there really was not a standard way to reverse them. There is a saving grace. There are now reversal agents, either FDA approved or in production. The first one, Praxbind, is the reversal agent for dabigatran. This is a phase 3 trial that actually our center participated in. It is now out and FDA approved. So you have a reversal agent for Pradaxa. That's out there. And that was interesting. That study was a single-arm study reversal agent that got FDA approved. Unfortunately, andexanet, which is the 10A inhibitor, was also a single-arm study with a phase 3 study that our center participated in, but it's not FDA approved. FDA now wants something as a comparison group. So we're still a little bit late on the 10A inhibitor reversal agent. The direct thrombin inhibitor is available, FDA approved. I recommend you get it at your center if you don't have it. And the 10A inhibitor right now is still going to be just in phase 3 clinical trials. So that same study that's coming out this month in American Surgeon, we looked at mechanisms and injury patterns in geriatric patients. It was interesting. I wrote a book chapter on geriatric trauma about 1.5 years ago, and I was amazed at how little there was in injury patterns stratified by mechanism for geriatric patients. There really wasn't much listed on that, and so, published on that. So we decided to take this study on, look at the National Trauma Data Bank. So if you look at the mechanisms on the left, and again, younger and geriatric patients, falls, no surprise here, right? I told you it's an epidemic. It feels like an epidemic. It truly is. 80% of their mechanism of injury is a fall. And on top of that, 80% of those are falls from standing. So this is where really we need to focus our attention. 80% of their mechanism is falls, 80% of those are falls from standing. So this is a huge problem in the 65 and over population. And in fact, once they fall and come into your hospital, they're at risk to fall again. Right? This is a study we looked at inpatient falls, and age, for every year older somebody was, they had a 2% increase in the risk for falling. So once they've fallen and come into your hospital, they're now at risk to fall again in the hospital. So I think fall prevention programs in the hospital are critically important to prevent a secondary fall, which comes with injuries and sometimes serious injuries within the hospital. The other mechanisms are obviously more common in younger patients: motor vehicle crash, autoped, assault, motorcycle crash, thank goodness, not very common, and then other mechanisms. So falls far and away more common in older people, and then all the other mechanisms more common in the younger population. Well, what about injury severity? How severely injured are they? Well, in reality, they're less severely injured than the younger counterparts, right? They sustain less severe injuries across the board, and you sort of see that in your practice, right? You see a young guy hit by a car, it feels like they're just destroyed, or an older gentleman hit by a car. They actually look pretty good, and then until you realize you delve into their physiology and their ability to adapt to that derangement. So less severely injured, however, they're more likely to have severe head injury and severe lower extremity injury. Again, for those of you who assume take care of a lot of geriatric patients in your trauma centers or in your pre-hospital setting, this is not surprising, right? More likely to have severe brain injury and severe lower extremity injury. What about specific injuries? Again, this is going to be looking at specific injuries stratified by mechanism for these populations. So in falls, younger people in falls are more likely to sustain a skull fracture or a facial fracture, and then some other kind of torso injuries as well, rib fractures, spine fractures, and abdominal injury. But think about younger people falling, much less likely to be a ground level fall, right? We're talking about falls from construction sites or houses or staircases, things like that. So the torso injuries are not surprising. Older people falling, 23% traumatic brain injury. A quarter of the patients that fall have sustained a traumatic brain injury, right? And then not surprisingly, hip fractures, pelvic fractures, lower extremity fractures. So you think about, same we talked about in the severity of injury, they sustain head injuries and lower extremity injuries. What about ground level falls? Who's going to fall? A young person is going to fall from the ground level, probably going to be drunk and just sort of fall on their face. This is not surprising. Skull fracture, facial fractures, and maybe some abdominal injury more commonly. Older folks, they're going to get hurt. Ground level fall, they're going to get hurt, right? Much more common to sustain a brain injury and upper extremity fractures, rib fractures, spine fractures, and lower extremity fractures. So much more common to sustain significant injuries as an older person with a ground level fall. Motor vehicle crashes, more common if you're younger, again, to get skull and face, abdomen, and lower extremity. This is kind of a scary stat to me, right? So you still have a pretty high incidence of traumatic brain injury, 18% after motor vehicle crash, but 40% sustained rib fractures. 40%. That's a huge problem in somebody who's already compromised from a respiratory standpoint. Now you put rib fractures on there. It kind of can be a real catastrophe. So look for those rib fractures. Spine fractures, 22%, again, fairly high. And this is the one mechanism where they don't get hip fractures, right? Really not very common at all. Autoped, younger, again, more common to have face fractures. Older, more common to have lower extremity fractures. Pretty consistent pattern across most mechanisms. They're going to have lower extremity fractures. What about assault? You think about a young person getting assaulted, they're going to get hit, beat about the head with fists or feet or some, baseball bat or whatever, so you get skull and face fractures. Geriatric, it looks a lot like a fall, right? They probably get assaulted and then they fall to the ground. If you look here now, assaults on the left, ground level fall on the right, they look very similar as far as injury patterns, right? Traumatic brain injury, upper extremity fractures, rib fractures, spine fractures, and lower extremity fractures. So you think about a person who gets assaulted, unfortunately it happens, I'll talk more about that in a little bit, they're going to get assaulted and fall and sustain the same sort of injuries they get from a ground level fall. So elder abuse, right? This is something that's hiding in plain sight, and I suspect we see this a lot more than we realize, and it's important, I think, to talk about. There was a great review in November 2015 looking at elderly abuse in New England Journal of Medicine. It was first described in the 70s, and it's reported to occur 7 to 10% of the time. This has to be underestimated, right? This is probably a gross underestimation. It happens much more often than we realize. So this can be broken down into several categories: physical abuse, verbal or psychological abuse, sexual abuse, financial abuse, and probably the saddest representation of neglect. So physical abuse is kind of what you would expect: bruises, lacerations, fractures, burns, and so on. What's the challenge about physical abuse is when do we see these patients? They're involved in a trauma, right? So they're going to have bruises, lacerations, burns, fractures, things like that. So I think if the story doesn't really fit, just like you look for non-accidental trauma in kids and domestic violence in women, we should be looking at strange patterns of injury in elderly trauma patients and make sure we're not missing a case of elderly abuse. Verbal and psychological abuse, this can be a little more subtle with sort of, deferring to their care provider or the care provider treating verbally abusing them in front of you during your evaluation. And so seeing that interaction between the elderly patient and their care provider and or family is kind of a critically important of our evaluation history and physical. Sexual abuse, like you would imagine, bruising around the genitalia, lacerations, newly acquired STDs. I suspect this is probably, again, underestimated because I don't know that a thorough genital exam is part of our geriatric trauma evaluation. But I think, if the story doesn't fit, you may need to incorporate that into your initial workup. And then financial abuse is kind of what you would expect. They can't pay, they can't get their medications, they can't get their follow-up care, they can't get to appointments. All these things should trigger red flags for you. And a lot of these patients should be funded, right? Should be funded with Medicare. And so the fact that they can't take care of their financial situation on the medical side should really catch your attention and potentially dig into this a little further. And then finally, neglect. the decubitus ulcers, malnutrition, dehydration, poor hygiene. All these things should really draw your attention to the possibility of elder abuse in this population. And this is really on us, right? This is on us as the care provider to look for these signs and symptoms of elder abuse, identify it, and intervene and do something about it. So what about when that patient arrives to your emergency department? How should we be managing that patient when they arrive to the emergency department? Well, the first thing is going to be we need to activate, right? So we've worked in our region to get our pre-hospital providers to increase the level of activation for age, as well as our internal activation for age increases as well. So if you're age greater than 65, you get moved up one category just based on that. And there's been a lot of work from a lot of different centers looking at increasing activation or changing activation criteria based on age, and they consistently show improved outcomes in the elderly patients, specifically mortality. So you need to go back and look at your activation criteria in your trauma center or your EMS system and say, are we really activating appropriately for the elderly trauma patients? You know, pretty minor mechanism, but they're 65, consider activation. Pretty minor mechanism, 65, and anticoagulation, I would say for sure you need to activate for those patients. So look at your local criteria. This is really a local phenomenon that we need to look at and say, are we activating appropriately for these older folks? And it requires resources, right? You're going to have to you're going to have to put out resources in order to activate your full team for this patient population. So what about when they arrive? What's your workup going to be? Well, a type and cross, obviously, if you have to transfuse blood. And then a CBC and a CMP I don't think is really all that useful in young people. I think it's very useful in the geriatric population. You're going to have electrolyte abnormalities, you're going to have chronic renal failure, and knowing that up front is going to be important. A lactate may be your one sort of clue that the patient's in shock. Remember, the physiology is not going to show you shock necessarily, right? And if they are hypotensive, you're probably really far behind. But that lactate may be an early sign that that patient has a perfusion problem that you need to address. And then we talked about the epidemic of anticoagulants and antiplatelet agents. These patients need to have a PT, PTT, INR, and in my opinion, a thromboelastogram. That's a routine part of our geriatric trauma patient evaluation. It gives you a snapshot of where they are from an anticoagulation standpoint. In addition, looking at their bag of medications or trying to get a history from them or their care providers to what medications they're taking. And I know we're in a cost containment era today, trying to save costs. This, I think, is a population where the risk of missing an injury is so catastrophic that I think it's important that we are very aggressive evaluating these patients. So we routinely get plain films on all these, chest x-ray, pelvis x-ray, fast exam on all these patients, even from the fall from standing, and then we'll talk about how that drives our evaluation. So what about CT scanning? I'm going to editorialize a little bit here. We argue a lot at conferences about why we don't want to scan kids, why we don't want to scan young adults. I cannot think of a rational argument why you would not want to scan an elderly trauma patient, right? Because when does radiation risk kick in? 20, 30, 40 years from now, right? So that's really not pertinent to an 80-year-old individual, okay? So you got to realize where you are in the spectrum of life and how aggressive you can be scanning. So the radiation risk to me, even for a 65-year-old, a younger, older person, is really not that important to me. And missing an injury, a head injury, is critically important to not only me, but more importantly to that patient. So no radiation risk. The cost to the system is zero. You have a CAT scanner that's plugged into the wall. You have an X-ray tech already there. So there really is no cost to your system. Charges we can argue about, right? You're going to charge that patient more money if you get more CAT scans. That I get. However, I think that charge is important because if you pick up an injury that otherwise would have been missed, you may save that patient either their life or a significant disability down the road. So how common are traumatic brain injuries in elderly trauma? We looked at this in a different way earlier by mechanism, but about a quarter of the patients, geriatric trauma patients, sustain a traumatic brain injury, right? 23% for falls, up to as high as 25% for assault. So traumatic brain injury is very common. So why is it so common? Well, as the older brain atrophies, it pulls away from the skull, and those bridging veins get on tension. So you have veins that are on tension, you get a little rattle from fall from standing, those veins tear, and they bleed into their brain or around their brain. In addition to that, you have anticoagulation, right? So a bleed that would be a little bleed normally is now a huge bleed from anticoagulation. So it's a common problem, and it's continued to be a common problem in this population. So how do we normally evaluate somebody for brain injury? We have clinical rules, right? We have the New Orleans head CT rule and the Canadian head CT rule. Great rules, very sensitive. You can just pull up on the internet and look at them and click the buttons and say, okay, this patient does or doesn't need a CAT scan. So here's the New Orleans HCT rule. If they have headache, vomiting, intoxicated, amnesia, visible trauma, you would get a scan. The only problem with this is if they're over 60, you can't use that. You can't use the New Orleans HCT rule because it doesn't apply to elderly trauma patients. In the same way, the Canadian head CT rule, GCS, possible skull fracture, so on, you can't use in people over 65. It doesn't apply to our patient population. So geriatric patients, you can't use these two clinical rules to evaluate them for brain injury. And why is that? Why do old people hide their brain injury? They have a lot of space, right? Their brain is atrophied, there's a lot of space, a lot of blood can go in their brain, and they have no neurologic deficits at all. So they go from a GCS of 15, and they look great for 2 hours, and then all of a sudden their GCS is 6 and herniating, right? They can really hide blood in their brain. So these clinical rules don't apply. And so along with the high risk for brain injury, the bridging veins and the atrophy causing bleeding and the anticoagulation, I would say every single geriatric trauma patient should have a head CT. I can't make a rational argument not to scan that patient's head when they come into your trauma center. So I would advocate for a liberal head CT in geriatric trauma. What about cervical spine? Not quite as common. Fall 9%, ground level fall 7%. Car crash, pretty common, right? 22% incidence of spine fractures and car crashes. And then autoped and assault, again, 16 and 10% respectively. Same thing, we have clinical rules we can use for young patients, the Nexus criteria and the Canadian C-spine rule. Well, same problem with these rules for spine injuries is that sensitivity in younger patients, 99 to 100%. However, in older patients, the sensitivity is only 65 to 85%. So the question is, are you willing to miss a third of spine fractures? Are you willing to take that risk? I'm not, right? I'm not willing to miss that. Canadian C-spine rule, same thing. You can't use this in age greater than 65. One of the indications for imaging in the Canadian C-spine rule is age greater than 65. So similarly, we don't have clinical rules we can use for elderly trauma patients, and for this reason, I think we should scan everybody again. So to me, the basic part of the geriatric trauma evaluation is a head CT and a C-spine CT, and this is now built into our geriatric trauma algorithm. They all get a head and C-spine CT. And again, this is trauma patients, somebody that fell, somebody that was in a car crash, somebody that fell from standing. They should have liberal imaging of their head and cervical spine. So let's talk about the torso. What about torso injuries? It's a little bit different, right? Chest injuries, not that common until you get down to real mechanisms, right? A motor vehicle crash, 43% chest injuries and 41% rib fractures, autoped 30%, assault 16%. So not so much torso injury in falls and ground level falls, but you get a real mechanism, you start getting significant rates of chest injuries. Spine fractures, again, not so much in falls and ground level falls, but you get mechanisms like car crashes, your incidence of spine fractures goes way up. And then abdominal injuries, fairly uncommon to almost rare, really, for falls and ground level falls. But MVCs have an 11% incidence of abdominal injuries. So you can see the torso is a little bit different than head and C-spine, right? The torso is, if you fall on ground level fall, you don't have to worry so much about the torso, but real mechanisms, car crashes, autoped, it should be on your radar. So who needs a torso CT scan? And when I say torso, again, this is back to the radiation discussion. Don't get little snippets of just the chest or just the abdomen or just the pelvis. Just scan the torso. If you're going to take that elderly patient to the CAT scanner and put them at risk for being out of the ER or out of the ICU, just go ahead and get the whole scan. You don't have to give contrast. You don't have to give any contrast, right? You can get a lot of information. But get a scan. If you're going to get a chest, get the torso. If you're going to get the abdomen, get the entire torso. Chest, abdomen, pelvis, and spine. So can we have do we have clinical decisions to help us for the torso? They didn't help us in the head and the C-spine. Can they help us in the torso? Unfortunately not. This is the Nexus chest decision instrument, and age greater than 60 needs imaging of their chest, right? Now that can be a chest x-ray, sure, right? But if that chest x-ray is abnormal, you need to follow that up with a CAT scan of their chest. But you can't leave a geriatric trauma patient unimaged if they come into your trauma center. Abdominal CT scan, this is probably the most risk of missing an injury, but you're also balancing that with it's not very common. It's not common to have an abdominal injury as a geriatric trauma patient, and this is by far the least amount of evidence. Probably the best algorithm I saw as far as scanning the abdomen is the East guideline. If they're stable, if they don't have a reliable physical exam, you image them, right? So you can determine that at the bedside. Is the physical exam reliable? You can consider imaging. If it's not, you consider imaging them. If it is reliable, look for physical findings. tenderness, rib fractures, abdominal wall, contusion, and that's to lead to imaging of the abdomen as well. What about the thoracic and lumbar spine? This was a large multi-center trial published last year, prospective study, 3,000 patients, 13 trauma centers, including ours and several of the other authors and presenters in the audience. You look at the thoracolumbar spine, another rule to use to work up these geriatric trauma patients. Unfortunately, age greater than 60 is imaging is indicated. Again, so you see that these patients don't fall into our typical decision-making rules that we have for head or spine or torso, and it's a difficult group to work up. So, and this is my opinion, for who should get a torso scan in the geriatric population. Well, it depends on mechanism, right? If they were in a car crash, autoped, I'm going to scan that patient's torso, right? Now, I think you can make a really valid argument if it's a fall or a ground level fall, maybe an assault, you may kind of see how they look clinically. Use your physical exam, your history and your physical. Do they have pain anywhere? Do they have any bruising or tenderness anywhere? Scan them. If they have physical findings on their torso, scan them. Abnormal chest x-ray gets a scan, a positive FAST exam gets a scan, and a significant pelvic fracture gets a scan, right? But it's a little bit, I think, scan everyone's head and C-spine. The torso, you can be a little more selective when taking care of these patients. So what about outcomes? Unfortunately, outcomes for geriatric trauma patients are worse across the board. Every single study published. There's no study that says geriatric patients do better than younger patients. Their outcomes are worse by definition. So you've got to realize that. So once they have sustained the trauma, the outcome is going to be worse than it would be for a younger person. On top of that, you add frailty, you add comorbidities, you add medications. It's really kind of a bad combination. So really, I think the most important thing for geriatric trauma is prevention. We're going to try to prevent this from happening in the first place. Education and then intervention. Right? This is kind of a scary slide from the CDC. Every 20 minutes, an older adult dies from a fall in the United States, and many more are injured. Every 20 minutes. So this one slide I have on injury prevention, I could just put this up for the whole 45-minute talk, and I think would have been most bang for your buck, is if you're not involved in fall prevention programs in your hospital and in your community, you need to be. Right? This is probably the most important thing we can do to intervene and improve outcomes in geriatric patients is don't let them fall. Right? So we currently are involved in Matter of Balance and Stepping On. I found this Tai Chi for arthritis. I want to start doing Tai Chi for arthritis. I've got some arthritis as well. But there's a lot of programs that are evidence-based programs that you can use for fall prevention, not only in your hospital, but also in your community, and keep these patients from being injured in the first place. So I think we've covered the objectives today. The physiology of aging and frailty, they are different than younger patients. They have physiology that affects their cardiovascular system, their pulmonary system, their renal system, and their GI system. And frailty is going to come with age. It's not directly associated, but you're going to have patients that are going to be frail and vulnerable to any adverse problems in their hospital stay. Expect comorbidities, particularly hypertension, and realize they're probably on medications, particularly diuretics, beta blockers, anticoagulants, and antiplatelet agents. The mechanisms, 80% are falls, 80% of those are ground level falls, and the injuries you really got to focus on are brain injuries, spine fractures, and then the lower extremity fractures that are very common in this population. The geriatric trauma evaluation, you're going to want to activate liberally, both pre-hospital and in-hospital, and work these patients up thoroughly with lab and CAT scanning in a liberal way to make sure we don't miss any injuries. And then by far and away, the most important part that we play in taking care of geriatric trauma patients is injury prevention, specifically fall prevention. Get those set up in your communities. With that, I would like to again thank the program committee and the board and all of you for joining me today. Thank you very much.